Good morning to everybody. I'm really happy to be back here after so long time, and it's a really pleasure to discuss with you this topic. So, defining the complex procedure, I think we have to go for anatomical factor, clinical factors, and comorbidity of patient, as well as operator experience in techniques, whether in surgery or angioplasty, for complete equipments in the cath lab, of course, with high experience and dedicated teams for every strategy. Now, in technical issues in distal left main, we can see that there is various scenarios in distal left main disease, and we have really different strategies for stenting in distal left main, starting from provisional stenting, that means simple stenting, going to more complex with different techniques, but what is mostly used today in clinical practice is T and tap, crush with mini crush and DK crush, and culotte as well as mini culotte. Now, let us go back and see the evolution of stenting strategies in bifurcation lesion. We started from single stenting in bifurcation and observing what will happen to side branches. Then this was defined as provisional T stenting, adding the kissing balloon inflation after stenting main vessel. Then we went in 1996 to T stenting, which was introduced as a new mode for approaching the bifurcation. And you see there was nice steps here, starting from main vessel and going to side branch. And this was modified starting from side branch and going to main vessel and so on. Then Culotte stenting were introduced in 1998. And again, different steps starting from main vessel, and you can see how long segments of both stents were overlapped at the beginning, as was proposed as an alternative stenting technique to T-stent. Then VU stenting, again in 1998, was introduced as a trouser-like stenting, and again defining different steps how to deploy the both stent in bifurcation. And finally, in 2003, crush stenting, which derived from T stenting. And you can see now we have a crushed stent with 3 layers of stent beyond the orifice of side branch, but this was accepted since it was demonstrated to be safe. So what is different at the present time? Well, we have different platforms with different designs and more appropriate strut thickness and cell opening for the use in bifurcation, more detailed data coming from bench testing and clinical practice, more use of intravascular imaging for procedure guidance, more effective devices for calcified lesion preparation, improvement of the basic strategies I have mentioned before, and more clinical data with improved outcome. Now let's go back to different platforms, and you can see that what we had in the 90s was not that much adequate for bifurcation stenting. And the new generation, that means contemporary coronary stents, can see that we have much better technologically platforms with wide open opening cell with low strut thickness. And of course, we have much data, so many data coming from bench testing, and we know exactly what to do and how to conform the stent to the bifurcation anatomy and to get the best outcome in technical terms. And intravascular guidance in left main interventions. We learned about carina shifting from intravascular guidance. We learned about where to cross, the crossing of the stent to side branch distal rather than proximal. We learned also how to expand the stent, the different measurements around the distal left main bifurcation to obtain the maximum benefit for the patient, as well as the how to debulk bifurcation was coming and understood from intravascular imaging. And now we have so many data coming from studies confirming that the guidance by intravascular imaging can improve significantly death, can improve myocardial infarction, can improve stent thrombosis in bifurcation lesion, and particularly in distal left main. We have more effective devices for calcified lesion debulking and preparation, which have a key role in procedural success and leading to a favorable outcome. Now, let's go for in the improvements we done on the basic strategies. This was coming from what we have learned from bench testing and what we have learned from our clinical experience. And now you see that provisional stenting and reverse provisional, that means whether you are deploying your stent in main vessel or from side branch to main vessel, then you have to follow these steps. That mean opening pot first, then opening the strut, then going for kissing balloon and final pot. The same you are doing when you are doing a reverse provisional. T and tap technique coming from T stenting, basic strategy, and now you can see how we can avoid leaving gaps at the bifurcation, protruding a small segment of the stent in main vessel. Culotte, again, it is not done as in the first description, since we are improving the expansion of the stent before putting the second stent. We are limiting the overlapping of stents to minimal part, that means mini culotte. Then this was leading to a more favorable outcome. DK crash coming from crash technique, and this again limit the overlap stent, that means the protruding stent, the crash stent. Then avoiding to leave 3 layers of struts in front of the ostium of side branch by making a first kissing after crushing the stent in side branch, and then again confirming the stent to the anatomy of the bifurcation without bulky accumulation of metal in front of the side branch. Mini crash means that one step less than DK crash, but we still leaving 3 layers of stent struts in front of side branch ostium. But this is still used in clinical practice. Now, these are the bifurcation strategies I have described before, but I would say that today operator experience in mastering a particular optimized double stenting technique is probably more relevant than the specific technique itself. And I think that stepwise, performing stepwise any procedure of complex stenting can lead to optimal clinical outcome. Now let's go finally to clinical data and showing something that starting from early ages, that mean in 2008, this was comparing T stenting to crash to V stenting. You can see there no difference between these 3 approaches, but no pot was used in these studies, and no kissing balloon inflation was done only in 49% of cases. Again, another study comparing T stenting, mini crash, and culotte do not find any difference between strategies in terms of clinical outcome. That means in survival with free of target lesion revascularization, as well as mortality and myocardial infarction. Now, simple stenting, that means one stent versus two stents, again, not showing differences between the approaches. And again, this is coming from Excel, particularly in distal lift main, and showing that provisional stenting is doing better than two stents, but we do not have any information about side branch lesion length, which is not reported in the study. And finally, EBC main study published early this year and showing that side branch lesion length was short, that means in provisional stenting was 5.8 millimeters, in systematic dual stent was quite 8 millimeters, and look on this data, that means 22% of cases shifted from provisional stenting to two-stent technique. And I don't know whether we have to consider this a complication of provisional stenting or not. Then the study did not show any difference between provisional stenting and two-stent technique. But finally, and for the first time, a study trying to define simple and complex bifurcation and to select accordingly the appropriate strategy. This was definition 1 study, which defined what is complex and what is simple accordingly to minor criteria you see here in this slide, and two major criteria. So one major criteria plus two minor criteria will define the complexity of bifurcation. Then if we look on the data coming from this kind of classification, you can see that simple bifurcation is doing much better. That means significantly better than two stents in simple bifurcation. But if we speak about complex bifurcation, then two-stent technique is doing significantly better than single stenting. And now let's go to see what happened if we compare what we are using today, that means the strategies we are using today in our clinical practice. That means crush, mini crush, culotte, DK crush, and tap, compared to provisional stenting. And you see from this slide that DK crush technique is competing with provisional stenting. Culotte is equal, but crush and tap is inferior to.
Imad?
Yes, I'm finishing. Yes. Yeah. And again, you can see here that regarding death, again, DK crush is doing better. Myocardial infarction is doing good with DK crush, better than even provisional stenting. But if we look on stent thrombosis, then tap is the worst technique to use, as well as crush or mini crush. And again, confirming that the length of lesion of up to 10 millimeters is determinant in selecting the appropriate strategy. That means more than 10 millimeter lesion length on side branch will do much better with two-stent technique rather than one stent. And again, another analysis confirming what we have seen before. That means DK crush is competing with provisional stenting, but culotte also is not doing bad. TAP is, you see here, is doing the worst work, the worst job if we consider stent thrombosis. Again, this is another study, meta-analysis comparing, these strategies and showing, again, that DK crush competing with the provisional stenting, TAP is not the case to be used. And finally, this work coming from PARC, from Azan Center, showing how planning the procedure accordingly to intravascular imaging guidance, as well as stent expansion, that means optimization after stent implantation and lesion preparation, will lead for a more favorable outcome in terms of MACE every time you are doing complex bifurcation.
Thank you, Imad.
Operator experience is very important. So coming to my final remarks, I say that the key points for study selection is good experience. Plan your procedure accordingly to lesion characteristics and complexity. Lesion preparation is essential for a good stent expansion of the position. Stepwise approach, whether it is simple or complex. Intravascular imaging guidance for procedural planning and optimization is highly recommended. Thank you very much.
Thank you. Thank you very much. Thank you. Okay.